What is the role of surgical management in the care of a child with chronic sinusitis?
It's very important to realize that surgery in the care of the child with chronic sinus disease is the last option and should always be the last option. So in general, we adopt a very conservative approach towards doing procedures. It is everybody's understanding, and the literature supports that medical management is the mainstay. So it's very important to manage each infection appropriately, look for underlying or coexisting comorbidities such as allergic rhinitis, possible immune deficiency, cystic fibrosis, gastroesophageal reflux disease, identify and treat those problems. And if one has persistent disease, despite maximal medical management that is documented by an objective tool such as a CT scan, then surgery becomes something to consider.
How can the patients benefit from surgical management?
So once you get to the point where we're entertaining surgery, one of the big differences in children versus adults is the role of the adenoid tissue. So there is reasonable evidence in the literature that supports the fact that the adenoids act as a bacterial reservoir, analogous to their role in chronic otitis media in children. So if you think about what are the approaches for the child with chronic sinusitis, the initial and simplest and first surgical approach that we most espouse is an adenoidectomy. The success rate for that in improving symptoms is about 50 to 60%. If you do a maxillary sinus wash in conjunction with the adenoidectomy, which is a reasonably simple way, then you enhance the success rate up to close to 80%. And for patients who fail that, then the next step would be an endoscopic sinus surgery. And it's a limited surgery. It's not as extensive as what you see in grown-ups. I also have to mention a few points. There are some patients who need surgery early on and are exceptions to the rule. And these are, for example, patients with cystic fibrosis with bilateral nasal polyposis and whose sinus problem is affecting the lower airway, patients with allergic fungal sinusitis, where you see very large polyps completely blocking the nasal cavities, or patients with impending complications such as orbital cellulitis and or brain abscess related to sinusitis. Those deserve relatively quick surgical intervention, but those are the exception, not the rule.
What is your take-home message for physicians?
I would, important to tell general practitioners and allergists that their role is very important in the management of the child with chronic sinusitis. They should investigate for existing other problems such as allergies, potentially immune deficiency, and treat conservatively. Do not overtreat with antibiotics is a very important take-home message. So the patient with chronic sinus problems, there's a significant good role for saline nasal irrigation, for treatment with an intranasal steroid are all reasonably beneficial and will hopefully keep the disease under control, and reserve antibiotics for when there's evidence of acute exacerbations or purulent drainage so as not to overuse antibiotics. And I think the majority of the kids will do just fine.
Where is surgical management of chronic sinusitis headed in the future?
I think the biggest thing, if you look at the literature that's out there related to sinusitis and its surgical management in children, most of the studies are reasonably well done studies, but they're all retrospective. The patients are not randomized. And there is really no stratification for severity of disease in these studies prior to the procedures. What I see that I believe needs to be done, unfortunately it's a little logistically difficult, is probably a multi-center trial across multiple academic or non-academic centers where patients will be matched for disease severity initially with symptom scores and a CT scan, and then randomized to adenoidectomy with a wash. Potentially there's balloons are being used for children to dilate maxillary sinuses, adding that as an arm, and endoscopic sinus surgery, and then evaluating these kids over a year or two in a prospective, randomized, well-controlled fashion. I think that will give us very useful information as to the best modality and the safest modality to provide best results in the future. I think that's what we should do. The fact that each individual center does limited number of procedures, makes this mandatorily a multi-center trial to power it enough to detect significant differences. So that's where it's logistically a little hard to organize.
That was very helpful. Thank you.
Thank you for having me.